Today on Leaders in Healthcare, we're tackling the crisis behind the crisis, the immense administrative and staffing pressures threatening Canadian medical clinics. Our guest is Kyle Sherritt, Vice President of Sherritt Services, a company that has been on the front lines of medical administration since 1997. In this episode, you'll learn how evolving payment models are creating new complexities, why the traditional clinic staffing model is breaking, and how virtual support is becoming a critical tool for building a more resilient, profitable, and sustainable practice. Get ready for a masterclass in the business of modern medicine.
What's the latest in billing?
Physicians are billing for themselves. I'm doing my own billing, and it pays. So I'm not doing it wrong. No, it doesn't. Yeah, it pays, but it's not right. Physicians will shortchange themselves. By staying away from overbilling, they're going to bill 90 or 95% value. 10 points over the year is a vacation home at the end of your career. We're going to educate you as to what needs to be detailed and where.
What is the most lucrative province to be in?
It's going to be Alberta. When it comes to reception services, let's do remote administration as well too. Like what problems can be solved remotely? Everything short of touching patients.
Arbitrage of cost of living difference between wherever the clinic's located. Virtual MOA might be somewhere more reasonably priced. Your company's been serving Canadian clinics since all the way back to 1997. From your vantage point, what are the biggest structural changes you've seen in how medical practice is operating over those last 25 years?
I've been involved in Sherritt since 2009. Okay, so since 2009 when I came in, there's been layers of different change. So originally it was like a matriarchy almost, like where clinic managers, a lot of them being female, matriarchy, would be in charge of everything, like completely taking care of the business aspect of everything for physicians, from making sure staff was taken care of, the like rooms were set up, ready to roll, billing, you name it, everything, advice, absolutely every aspect of it. It has really shifted from that to physicians self-managing over the years. And one of the biggest things has to be basically taking advice from other physicians instead of business managers, I think would be one of the biggest changes that I've seen happen in the last 16 years, for sure.
So that like monolithic single linchpin type person, because I can only imagine, they're going to go on a mat leave, they're going to get sick, they're going to, have things happen with their kids, they're going to go on vacations, right? And so if you have like just that cornerstone of a person, that single individual just holding the whole clinic together, that makes it really difficult to have that flexibility in somebody's life, to actually be able to get away, take time off, go on trips.
That person becomes, like you're saying, the cornerstone. And the personalities that are in that, and there's still a few around, for sure. I'm not saying it's completely gone, but in that person's life, it becomes family, bill paying, and then managing the clinic. Like they're not doing it because it's a job and they're being paid to. It is literally a part of their lives, is to manage that clinic, to manage the physicians, because it will fall apart. They know they're the cornerstone. Nothing can happen without them. So taking vacations looks different when you're one of those people. And that's the way that it was for the longest time. I caught the tail end of that in the beginning of my career, and you don't see very much of it. Few and far between. They still exist. They still are out there for sure. Like I can think off the top of my head a few different clinics that are working with us where they still are in existence. Actually, I have retired clinic managers that were those cornerstones working with us at Sherritt in different capacities, accounting and sales, and billers as well too with Sherritt. So we have them.
And so what is that, instead of having like the chief operating officer of the clinic, like you get the manager, what does that more distributed admin team look like now, or how does that actually work in today's modern age?
There's a lot of self-managed. So that's a loaded question, so I feel like there is a search for a modern solution for exactly what you've just described. So if there is a physician or a clinic out there, they're looking for that solution, that cornerstone. Like, what do we do, in order to manage communicating with patients, booking them in, managing 19 different layers of tech and software? How does that all come together? Like, there's a million different solutions out there for problems that might not even be on anybody's radar. So there's a ton of different solutions for that question. For me, myself personally, kind of loaded coming from me, the sales guy that's selling a solution, but there's ways that you can outsource different problems. There are things that definitely need to be managed internally, but the less noise that physicians and clinics have in their day-to-day allows management of care to happen. Management of care looks a lot different when you're only worried about management of care, I guess is what I would say. So if if you have receptionists doing more than reception duties, if you have nurses and MOAs doing more than managing patient care, filing people to office, getting rooms ready, if you have physicians doing all of the above, and the administration, let's say, the back end of management of care. So what does it look like in a successful state, I suppose? Solo practitioner versus group. Like there's a lot of different levels of that question, Jordan. So if we have, let's say, a solo practitioner, you can have zero support staff, or you could have a receptionist, an administrative assistant, like an MOA. You can have nurses, you can have a clinic manager, and it can be you. So the business model changes depending on the individual. And I've seen success in a lot of different ways. It's kind of dependent on the geographic location as well too. BC, Alberta, Saskatchewan, Manitoba, Ontario, Nova Scotia have different opportunities to practice and to have that business model look different, right?
And then, like, how much has the technology changed that distribution of duties too? Like, are we actually seeing, I don't know, the patient check-in kiosks starting to become more popular and take over some of that admin task? Are we starting to see, like, the AI and scribes has been the big one, but are we starting to see other roles for the administration computing taken over?
Well, absolutely, in a million different directions as well too. So just the beginning part, we'll say kiosk check-ins. That happens. That's a thing. It's happening right now. We work with solo practitioners that have that model. So you walk into an office, and this is solo practitioners only, okay? This falls apart completely when you get into bigger group settings for a magnitude of different reasons. So I'll just touch base on the solo practitioner first. So you can walk into a solo practitioner's office. There's a tablet there, and it's essentially an EMR, a CHR, or a plugin to one of the above. You sign yourself in, make sure your address is correct, contact information, all that jazz, right? And then there is either digital sign or signage in the clinic, and it's going to say, after you've checked in, take a seat. Physician will be out shortly to bring you into the exam room. Physician will come out of said exam room with patient. Obviously, all communications happen in the exam room. Patient leaves, physician. A lot of times they'll have one or two rooms, okay? So where they'll get their room ready for the next patient. Patient will come in and they'll take care of whatever management of care has to happen. Now, the beginning and end of that visit aren't detailed in that descriptive. So when the patient comes into the office, there has been an appointment made prior to. There has already had communication happen. That communication has transpired, be it with an online booking or a third-party booking system, or a person that's communicated with that patient. The appointment's been created. After the patient leaves, now, depending on what's happened in that exam room, there's work that happens after the fact, like in regards to the administration. As you know, there's also work that you guys or physicians are doing after that face-to-face visit. Depending on the visit, does the patient need to be referred? Is there charts that have to be completed? Is there a follow-up call that has to happen? Like there's other work that happens. So the middle section of that patient experience is checking in using a third party or AI system. It wouldn't really be AI, but it'd be a tech. And then you can use scribe, or there is scribes that are happening or notes that are happening in the actual visit, where the EMR or CHR is listening to the visit and creating chart notes on said encounter, kind of thing. So there are many different layers of tech being used, and it's dependent on how the physician's practicing and the nature of what they're doing. You can see why that would fall apart in a multi-physician clinic where you have patients coming in, checking themselves in. There's a lot of noise, I guess you could say, in that scenario. So we're not quite there yet as to like self-managed large practices. There's humans involved as patients. So it falls apart at that with that variable, you know?
I imagine there's probably like a bimodal distribution there. Like you've got like the really small, lean HR teams, or even where there's perhaps just a totally self-managed clinic. And that's probably viable for one provider. And then as soon as you get to that next little island of, I'm going to say it's probably 2 to 5 physicians or providers, then you start having like the one person at, MOA or clinic manager, and then there's another, then you're in the 6 to 10, and then you're talking, 3, 4 people. And so it's probably very dependent on just how big the practice is as the main variable.
Yeah, and what kind of practices actually, so what the practice looks like. So GP specialists with subspecialties, like if you have a skin or a derm clinic as well too, or if you are, let's say, maybe just if there's a couple of different subspecialties that you can have where the clinic actually looks different. So you'll have 2 physicians to 5 will have the same amount of support staff, like for obstetrics, as well too, and as well skin things. You'll have you'll be really heavy in staff. And then if it's family medicine only, you can get by, you can have 6, 7 physicians that have the same as a 2-physician clinic for support staff. It's really dependent, and a lot of it's location as well too. In Vancouver, you're going to have 2 support staff, and because that's what you can find, and you're going to have in like High River in Alberta, you can have more support staff, just like because you can afford to have those people, and the conditions of the area, the geographic area that you're in, those people can exist.
Is that just a cost of living thing? Like the revenue is the same, as dictated by the provincial billing codes, but when you're further from the urban center, your operational expenses are lower?
Exactly. So let's say Toronto, for example, okay? In Ontario, physicians are probably the second lowest paid physicians in Canada in Ontario, and the cost of living is the highest. So if you have the least amount of money coming into your business, or one of the smallest amounts of money coming into your business, and the cost of living is highest, having somebody on your roster for $22 an hour is not viable because they're driving 2 hours to get to your office, and you can barely afford to pay them. Now that looks a lot different when you're in, let's say you're in BC, and you're in rural BC, and you're one of the highest paid physicians in the country, and the cost of living is, it's changing in BC right now, but it's a lot easier to live in Merritt, BC than it is to live in Toronto, Ontario, So it's different depending on where you are and where you're practicing, and what kind of practice that you've created, if it's a group or it's an individual.
I'm guessing that's where the premise for the virtual fractional MOA came from.
Yeah, it was a lot of calling around, actually so in selling our billing service, primarily we were a medical billing service. Sorry, Jordan. And then COVID hit, and I would be trying to sell a billing service still, and I would be communicating with clinic managers that would be answering the phones, and they say, Kyle, I can't answer, or I can't talk about billing. I'm answering the phones right now. There's a million other things that I'm doing. So we heard that enough, and then we created a service, a fractional service, to solve those problems for them, and say, I wanted to be able to call and say, hey, let's chat about billing, and if you can't talk about billing, I can solve that problem so we can talk about billing. And then it's really snowballed, and I think we're one of the only service providers out there doing what we're doing right now in the way that we're doing it.
Are you a healthcare professional ready to take the next step in your career? Do you dream of a role where you truly make a difference in a community that's perfect for you and your family? Well then, let me introduce you to Cherry Health. Our platform puts thousands of healthcare opportunities right at your fingertips. Explore jobs by location, specialty, compensation, and more. All on an intuitive map-based platform, available on Android, iOS, or your computer's internet browser. Create your professional profile for free and get started messaging directly with employers. Beyond the app, Cherry Health also offers personalized, white glove recruiting services who can guide you every step of the way. Your dream healthcare career is just a click or a phone call away. Visit www.cherry.health to start the next phase of your journey.
And so what's the uptake of the fractional MOA service been like? How's it been going now that it's been out for, it's been what, more than a year now, I think, right?
We started back in 2021.
So you've been doing the virtual fractional MOA for several years now.
Yeah. It literally during COVID, I tried to solve the problem that kept coming up, whereas people were trying to limit staff in office but still keep the practices going. It was just a weird time in COVID, and we had experience working remotely in healthcare. So there was that box ticked. Like, we've been doing remote services for physicians since RDC, or remote desktop connection, was the only way. There was no Zoom, there was no Riverside, there was no any of that, right? It was just RDC. So in that, using what we've learned over all of those years, we then put together the concept of, okay, let's do remote administration as well too. Like, what problems can be solved remotely? And we put together an amazing team headed by Jyoti. She's been here from the start. So, and in communication and R&D, we found that there's a lot of things that can be basically taken off of the clinic's hands, everything short of touching patients. So what I try to do, and what we try to say to physicians or clinic managers or whoever we're speaking with, is, where's the problem set at your individual site? It's different everywhere. It's like a clinic is like a living, breathing thing. So is it the phones need to be answered? Is it that there's documents that need to be linked? Like, can you not find somebody that speaks Cantonese that you need for 3 hours twice a week? Like, there's unique individual problems that can be solved in a fractional capacity. And then as you're contracting someone to do so, the unique problems that come with hosting employees are not an issue anymore. So there's layers of solutions, I guess you can say, by doing this. And we totally just walked into it being legit, like, let's try and see what problems we can solve. And it's everywhere. Like, the sky is literally the limit. We're working from solo practitioners that don't have any support staff to hospitals with 13 clinics inside of them, like everywhere in between that as well too, all over the country.
And so let's say I want to do a fractional virtual MOA then. How does that actually interface with the clinic? Like, if it's part-time, do I have to choose hours per week that they're available, and then they're doing asynchronous tasks, like maybe it's the inbox management or scanning documents or stuff that's not happening live? Or is there a virtual MOA answering the phones on your guys' end, but they're currently working for, let's say, 2 or 3 or 4 clinics, I guess, depending on the call volume, so that they're available for an 8-hour day, but you're only getting charged for a 2-hour window?
Yeah. So all of the above. So we have a menu that we've put together of services that we're providing all over the place. Now,
yeah.
If there is, let's say, a need for documents to be linked in the background because in-house staff manages the phones, let's say they don't want to take away too much from in-house staff. Franny's been working here for 30 years. We're not looking for a replacement. We need to give Franny support. So we're going to tick off the box on the menu and then the task list, I suppose, where we want Sherritt to be on our EMR working Mondays, Wednesdays, Fridays, let's say from 9 until 11. Okay, so 6 hours a week. That's one thing we can handle. When it comes to reception services, how is the practice created is the question, and how do you want your practice to be managed? Are we in an extremely remote location and we're going to create and we're going to train the clients, or sorry, your patient base, that the phones are going to be answered from 9 to 11 and callbacks will be coming back from 1 till 3, and you're utilizing a receptionist for 4 hours? Or do you need people available 8 hours a day on reception duty? Call in and call out, like inbound, outbound calls, everything and in between. And so if we're in an environment where it's 8 hours a day required, like we need you manning our phones, then that person's dedicated to that project, Jordan. They're not on multiple projects.
Okay.
At once. It's only solely that one. And by using that model, they're paying us to be their receptionist. We only work, it has to be VoIP phone systems too. So if we're talking reception, internet-based phone systems, they're Rogers and or Shaw and TELUS. Rogers and TELUS have amazing voice over IP phone solutions. And we utilize those ones where you just get a user seat, and then we are, like you call your clinic, we're the ones answering it. Everybody's remote and everybody is in Canada. Actually, it's the same province. Like we we try to be way over and above the Health Information Act standards in every way, shape, and form. We're not only in Canada, but we're in the same province. So basically someone in your community even could be answering the phone for you, but we're just not at the actual site.
Cool. So I guess that enables you to use that arbitrage of cost of living difference between, wherever the clinic's located, and then your virtual MOA might be somewhere, more reasonably priced, and then they're still able to work at that clinic without the 2-hour commute each way every day.
Right? Like you could be, and we do have, like if you're in Vancouver and you don't have to go to work, it costs money to go to work, right? Like, or travel time or fuel or public transportation, you have to get ready, you have to be there kind of thing. So it allows people to work. It allows people to do the job. And at the same point in time, maybe it's a fractional service that you need in one clinic. So if we have one site where you're going to work from 8 until 10, and another site you're going to work from 10:30 until 3:30. Maybe it's after hours support later. So you have your projects and our teams are built based on EMR and software knowledge, right? So if it's an Akiro team member, we place that person on our Akiro project. So everybody is just one project at a time, and it's depending on their specialty. So that's the thing that clients are also paying for, is when you're hiring us, and let's say we're just doing reception and document linking. Okay, so reception in the mornings, document linking in the afternoon. That person comes fully trained, right? That's the other thing too. So the biggest thing is staff retention and training. That's huge, right? So if I'm saying not only are we going to solve the reception problem and the actual administrative aspect of it, and you don't have to find the people, train them, or manage them. That's the kicker, right? Like that's the real one, because nowadays that's the problem. Finding software to solve a problem is not a problem. There's 9 different softwares to pick a problem, right? But people still have to operate that. The AI isn't quite there. There's no robots doing it. Answering actual questions and operating software still has to be done. You still have to know how, right? Training somebody to do so doesn't have to happen anymore when you're utilizing us. It's just, what are you using? What softwares? Okay, we've got a team member for that. Show us what you're doing, how you guys are individual, like what your individual needs are. We process, document everything, and then we go from there.
Very cool. And then I imagine that probably provides a layer of redundancy too. Like let's say virtual MOA from your guys' end is actually sick that day during the scheduled time for the clinic, then you still have a whole roster of other virtual MOAs available that can then be, that we're Akiro trained or we're on Oscar to jump in and fill in that role without the HR staffing nightmare of trying to have redundancy in the physical clinic with people actually there.
Yeah, and we solved the redundancy issue. So again, back to billing, we have people that float to every single project weekly. Sorry, it's a rotation, but they project weekly. And a lot of the times the staff doesn't even know that it's not the same person. We'll have 2 people on the project.
On call filling in.
Yeah, I mean, there are some certain ones where we can't do that, where we just train with them individually. Like there's some that projects where it's like 2-factor authentication to access sensitive data, so you can't do that. But what we do is we train weekly so that if that person was to be sick, not only do we have somebody trained on the staff, but the nuances of the actual site. So, and that's huge for billing, like absolutely massive for billing. And then we just rolled the same process right into the MOA side of things so that we essentially have zero downtime. Like
Cool.
if your biller or your MOA is sick that day or taking a mat leave or whatever it might be, the site is still operational.
You mentioned a little bit about like the privacy security. What are the considerations there? Like, does the MOA, virtual MOA, has to be in the same province as the clinic, or what else do you need to be aware of, I guess, for a clinic thinking about doing the virtual MOA?
Yeah. So now, gray area for certain provinces, and there's some companies out there that utilize that gray area. There are provinces, Ontario, for instance, like OHIP, you have to be in the same province. Okay. So
Hmm.
all of my Ontario clients have Ontario residents working for them. And then BC, similar. Alberta, very similar as well too. Basically, information can't leave the province. It definitely cannot leave the country. But certain provinces have different rules, and it's dependent on which province that we're talking about. If we want to say Ontario, which is the OHIP's the most strict, information on lockdown in the province, following all of the rules and guidelines. So as I said, like we follow the Health Information Act to the T, and the PIPA does. But we have a privacy impact assessment or Part B package that gets attached to all of our clients' PIA submissions, and it outlines the nature of what we do for mainly billing, because there's data transfer that happens for billing, not for MOA services. There's zero data transfer that happens for our MOAs, but very specifically, we've got a privacy impact assessment Part B for billing that outlines what we do, how we do it, data transfer, disaster scenarios, everything, as well as information managers agreements that exist. So for billing, super heavy on privacy documentation, rules, guidelines, same province, workforce. And then the MOAs, there's accessed information a lot of the times. So there's no data transfer that's actually happening. So the rules become slightly relaxed, be it like we can have somebody working in BC on an Alberta project. If we're answering phones and accessing an EMR, the risk has been limited, right? So is the main thing. And then we have our internal safeguards as well too. Like we've been in business for a quarter century in a remote environment in healthcare. There's probably not another business that has as many safeguards when it comes to data handling as us. And I won't even get into it, Jordan, because it'd be a 2-hour conversation. Like there's a lot.
You teach a seminar next week on the privacy and security side of things.
If you want to go in a national conversation about privacy and security, I probably have a fair knowledge base for everybody, like, just through experience, right?
Cool. Okay, so it's good to know. Like the PIA side of things is probably pretty turnkey. It's templatized. You just submit the addition. You're not having to go redo the whole PIA and explain what's in the makings of everything, because it's the same on your guys' end. And so that's just a
Yeah.
quick add-on for the clinic.
Yeah, absolutely. Absolutely. It was created as templated. There's different amendments that have to happen from time to time. We've been pretty lucky to maintain the same IT provider over the years, a lot of the same staff. Like our managers have been, I think, like Jyoti's been with us since the beginning. Sue's been with us since 2010 as well too, like for our billing manager. So a lot of that, we have redundancy in staff as well too. A lot of people stay with Sherritt. That's the other thing, like we try to, the people are our business, right? Like the people are Sherritt. So, and we fully understand that aspect of it as well too. So,
And then tell me a little bit more about the billing side of things. So this is where Sherritt got started. This is, I imagine, a big part of what you're still doing on top of the virtual MOA. What's the latest in billing?
yeah, I mean, it's ever changing. I guess the last couple of years has been, since COVID again too, huge changes. There's been changes, I mean, ongoing since I've been around in 2000, since 2009 to present. Different provinces have different things going on. BC, the last couple of years, they've put in a new payment plan that's absolutely amazing. The longitudinal family payment plan, there is family physician payment plan. Alberta has just installed a new one that's similar to PCPCM, where they're paying physicians for time as well as fee for service. And, there's a lot of shadow billing that happens. It's primary care in Saskatchewan. They're going to give you $600 a day, and you're going to do what you're going to do, essentially. And there is still a fee-for-service environments in Saskatchewan. Manitoba has, again, the last couple of years kind of copied a blended model between Alberta's fee-for-service and BC's LFP payment model. Really, the absolute back of the pack right now, and I hate to say it, is Ontario. Like, they have to do something. Like, they've got umbrellas of family health, and in my opinion, there's like political things that were involved, and that's kind of all been kiboshed. And some people are getting paid more or less for doing the same thing. And like, when it boils right down to it, physicians in Ontario are making like 20% less than physicians in Western Canada. It blows my mind. We bill for them all, and the concept is the same right across the board for us. What did you do managing the patient's care? How long did you spend doing so? Document what you've done, and then let's let someone else capitalize on that, or help you capitalize on that income. We hear a ton. The thing that I hear more than anything nowadays, physicians are billing for themselves more and more than ever. And they'll say, like, I'm doing my own billing and it pays, so I'm not doing it wrong.
Yeah.
Like, I hear that all the time, but it pays. No, it doesn't. Yeah, it pays, but it's not right. Like, you're not doing things right. Or a lot of times physicians will shortchange themselves. Nature of the beast. Okay. And this is just what I'm seeing. I'm not saying anybody's doing anything wrong, right, wrong, or otherwise. What I see is physicians will do what their colleagues say and say, hey, it pays, we're good, or they'll shortchange themselves. Nature of the beast, fire's hot, don't touch it, right? If you overbill, you're going to get burned, you're going to pay it back, you're going to be audited, and you're going to be flagged forever. So stay away from overbilling. And by staying away from overbilling, a lot of times they're going to bill 90 or 95% value instead of capturing everything on the table. So by utilizing Sherritt's method, which is have one person as your go-to contact to be your biller. We're going to teach you what is billable legitimately, what isn't billable, okay? And then we're going to teach you how to document what you've done. We're going to educate you as to what needs to be detailed and where. And we take that information, we produce a billing based off of management of care. What was done, there's, in a lot of different environments, there's multiple different things that can be billed and that will pay. And they will be accurate dependent on what's happened. Now, we can take that information. If you go see a physician and, just for instance, and you bill a physical visit, but you've actually chat about psychological whatever services, you need to chat about something psych related, okay? You can bill a physical service code and it will pay, but a psych code is actually accurate and it's going to pay more. And if you're in a rostered environment like BC or Alberta have, you're going to be receiving a panel payment based on the diagnoses that were submit with those codes. Okay, so your panel payment changes now if you have submit different diagnostic codes. So what we want to do is just clear all the noise off the table. So what did you do? How long did you spend doing so? Document what you've done. We're going to teach you what needs to be documented, but face to face, before or after the fact, whatever. We're going to take that, we're going to produce a submission, and then we're going to support it. So if something rejects for whatever reason, be it needs text supporting what's happened, maybe there's an 05A in Alberta, which is just like there's something wrong with your healthcare number, to be layman's terms, essentially. We have to go to healthcare and do the work, communicate with them. That's all part and parcel with what we do. So full management of a physician's finances, completely taken off of the physician and off of the clinic. And that rolls back to that there was a time when there was a clinic manager that completely supported all of this for the physician, and there was a biller in-house that would support that for the physician. Those people are few and far between now. So what Sherritt does is, from the billing side of things, is we'll be that billing person. We're going to teach the physician as to what needs to be documented. The difference between, let's just say in Alberta, okay, so I'll give you a couple of different examples. So in Alberta, the difference between a 29-minute psychological service, and a 31 is pretty big. 29, 31 minutes. We really needed to take care of your time before and after. In BC, in Manitoba, did maybe you were at your kid's lacrosse game and you decided to go sit in your car and review some chart notes or whatever remotely? Did you capture the indirect care time? In BC, it's worth $130 an hour. So if you went and sat in your car for an hour and did some work, and how do you capture that would be the next portion of the program. So we educate physicians on what they're doing in their day-to-day as to like what it's worth, kind of thing. So tell us what you're doing, tell us when you're doing it, and let's show you how to capture all of that. Hospital as well too, how do you manage a busy hospital shift? I was there for 12 hours. I saw these people. This is what I did. I saw 13 of them within 5 minutes. What do I do? Like, how do I bill that accurately, right? So it's layers. So you get your own billing person to answer all those questions, to provide the clarity, to create the ongoing relationship with. And that's the key. The secret sauce is that we're a long-term solution, right? Like long-term partnership. We make sure that the physicians are capturing all of their income. We don't charge a percentage. We're a flat rate fee for service. So you know what we cost, the nature of our partnership, you communicate, we educate, you make sure your money's maximized ongoing, and then we update. So if something changes for you, like new PCPCM came in Alberta here not too long ago, we're on the list. Like we are getting all of the information as it comes out. We train internally, and then we let you know what you need to know. Which, by the way, if you're in a city center like Edmonton or Calgary or Red Deer, PCPCM is a good thing. It is a great thing. BC, longitudinal family care, great thing. Like we have tons of different knowledge and advice that we can provide. What should you do? Where should you do it? Like what pays more, what pays less? That all comes with us.
Attracting top healthcare talent is crucial for providing exceptional patient care, but connecting with the right professionals can be time-consuming and complex. Cherry Health bridges the gap. Our network allows you to showcase your organization, post jobs with precision and ease, and directly engage with healthcare providers actively searching for roles like yours. Whether you're an ambitious do-it-yourselfer or a seasoned recruiter, our intuitive web platform makes it easy to showcase your open roles and organize your applicants. Need a more personalized approach? Cherry Health Staffing Solutions offers dedicated recruiters to find and vet the perfect candidates for your specific needs. Build your dream team with Cherry Health. Visit www.cherry.health and start growing your team today.
What would have average, let's say a family doctor in Alberta, what's the delta between the missed billing opportunities versus if they're going with a billing provider such as yourself? Like, are we talking 5%, 15%? Like what's typical for increase to the bottom line?
Typical is usually 20%, 15, 20%.
Wow, really?
Yeah, I've seen 50, but that was in a massive clinic setting where the staff was undertrained, there forever, completely misrepresenting the physicians. We doubled their income. The average solo practitioner, usually 10 points, a solo practitioner, just because for the nature of the beast, right? Like they're underbilling to try and protect themselves. Whereas when you start working with us, we really help you create like an accounts receivable of sorts, where we detail what we've done becomes 1. We produce a submission off of that, which is 3 or 2, and then the payment is 3, right? So it's if we set everybody up to pass an audit. That's what the goal is, right? Like if you're audited, your EMR is going to be audited, right? Whatever you're submitting on is going to be audited. You need to prove why you submit what you submit. We've been through audits as a company. We've never had a client pay $1 back in all the time that we've done this. And after you get audited as a Sherritt client, like it speaks volumes. If you want to audit a Sherritt process, they know what's coming, right?
Yeah,
so we've been there, and our team is vast.
How does the workflow change? I guess, like, let's say me, the doctor, right now I've put in my billing code and I've got my just chart note there. Like, what are your billing agents looking for from me to put in there if it's not the billing codes itself? Because I can't imagine they're actually reading through the whole encounter and the physical exam of like literally exactly what you did. So how do they then get the snapshot of what I did in order to maximize the billing?
They actually do, Jordan. That's
Oh, really?
hilarious. You say, yeah.
Okay.
So to be a biller and share it, you got to be interested in this, right? So it takes actually 2 years of training, and we train internally. We don't hire people with billing experience. So we train internally. You go over what was done, and so some physicians are long-winded in their chart notes, and some
Hmm.
aren't. So that comes with this is what your chart note needs to look like. If you want to go over and above that, great. Some physicians struggle with charting at all, right? Like that, just charting is a thing. April 2014 became a rule that you have to chart and include times on every patient that you saw. So
Yep. Yep.
we'll go through the chart. What needs to be there is detailed management of care to a degree, and time spent. And time spent isn't just face to face. So when we're onboarding a new client, it becomes show us what you're doing right now. So Dr. Valroth, we need to see what you're doing right now. What is your process? And from there, we make suggestions, because at the end of the day, we work for you. You are responsible for everything that happens, right? We can make suggestions. So let's just make sure your charts are complete, your times are there. We're going to come back 24 hours later if you're good at charting, 48 hours later if you're not so great at charting, because we want to make sure that everything face to face and after the fact is captured on that chart. So we're going to take the cumulative time plus 2 more minutes from 5 more minutes for reviewing labs, creating a referral, whatever you're doing after the fact in your chart notes. We take the total time, the total management of care, create a submission, be it are you doing head to toe? Just clinic here, okay? Just clinic we're talking about. Are you doing full head to toe? Is it maybe not head to toe, but you spent a ton of time on them? And then have you done work after the fact? And what actual services have been provided? Warts, treatment, PAPs, like what has been done in this visit? And then we're going to submit that based on what you've done. So yeah, they're actually reading the chart note, be it a scribe, be it whatever it is, taking the total time, and that is either managed by the physician or managed by tech. Like, is it when you punch in, it starts a timer, and then we're calculating the actual physical time, like 27 minutes, whatever it may be, or are we going off of your stopwatch that you've put in there? So we take everything that has been done, and then we produce a submission off of that. And there's a million different ways of accomplishing the same thing. There are physicians that work off of paper charts. There's physicians that use more tech than you could possibly imagine. And so the solution looks different. And again, the billing specialist that's put on that project is catered to the software and the physician. I think we have to be one of the only service providers that works on all of the software is the other thing. Like all of them. We've had companies come to us just for workflow suggestions, EMRs and CHRs. So yeah,
How to make it easier. Very cool.
yeah. To answer sort of short and sweet is we take what you're doing, and yeah, we do read through everything and then produce a submission based off of that.
That's wild though. Like just the fact that you can give yourself a 20% raise just overnight by doing the billing differently.
Yeah, totally. Like if you're working in a
I'm gonna get you
hospital,
guys looking at our billings here.
yeah, well, seriously. And what we tell everybody, so we're a trial contract as forever. Like I want to be a long-term solution because we're good at what we do. So it's month to month with Sherritt. So what we say, a month learning, month 2, you're going to see something a little bit different. Month 3, you're probably never going to change, is the way that it works. And if we're talking about a physician's income, increasing your income 10 points over the year is a vacation home at the end of your career. It's not like we're not talking about a little bit of money here. And just by doing things a little bit different, there is change that happens, but healthy change. How many times have you received a phone call from a nurse about a patient and you're like, meh, whatever, like just, it's worth $20. I don't care. Like just little things, like, or managing time. Maybe so if I'm a patient of yours and we are on this call right now and we've got, like, you can assume how much time we've spent, make a guess, but the difference between 45 minutes and 46 minutes is can be at $30, depending on what's happening. It could be 60, $70 depending on what's happening. So and it gets layered too. Like, are you delivering babies, or what are you doing in your day? Because there is a million different ways that physicians lose money. So we're not being creative. We're just saying, tell us what you're doing. This is what counts to tell us, like, these are billable services. And then we're going to help you capture this stuff 5% increase at a time, like, not based on being creative, just based on what you guys are doing. We're just helping you capture it by being interested in it. That's a lot of the times the billers are they're seriously, legitimately interested in what they're doing. So they're reading through the chart notes. They're making sure that you guys are staying healthy, I guess, from a financial point of view.
How often does the opposite become true? Like, you look through a physician's billings and you're like, oh, this person is aggressively billing like a madman. This is a huge liability to your career here. We got to dial you back.
Yeah, quite often. Actually, absolutely, that's happened. Like, we'll increase income and we'll decrease income for certain physicians as well too. You're not paying us to make you more money at that point in time. You're paying us to keep you practicing at that point in time, like, where we dial it back. Just, there's certain things you can't do and that you shouldn't be doing, right? So you get that specialty of us keeping you safe from overbilling or being too aggressive. Things that you can't do, like, we know the rules in and out. And we'll provide, like, that has definitely happened. Not as often as one might think, like twice a year I'll come across it.
Okay.
Those people keep us as their clients, though. It's not like, oh, like, I'd rather make more money, like, yeah, okay, you're, again, back to, but it pays, but it pays. It isn't a thing. Like, forget about but it pays. Like, that needs to never be a thing in a physician's mind again. Like, you could be overbilling, but at what cost, Like, that's just my 2 cents anyway. Yeah. If we ran into that recently, and a lot of times it's not malicious, like, it's never been malicious with us or anybody trying to maybe push the boundaries. It's like, I didn't know that.
Yeah.
I would rather do things properly, like, that's a lot of the times. And then they'll keep us on because, like, we've now dropped your income 10%, but you're now doing things properly, like, that's the thing. So, I mean, physicians, you guys can make a ton of money by billing accurately. Like, and province to province is different, but you don't have to pump through 1 million patients a day to, you can actually, like, depending on the province, you can make more money spending more time on your patients, like a 25 patient workload than a 40 patient workload in a day if you're spending more time with them. So, like, we give that advice as well too. If you're the personality that likes to spend an hour with people and you have 15 patients a day, like, you're going to make a ton of money. But again, it's physician personality as well too. So, like, how do you practice? Let's show you how to capitalize on what you are doing as a physician managing the care. And then building, Jordan, you can go, like, our billers will help you build your day, like chronic versus acute patients. Like, each block of time becomes a value. So if we say chronic patients in the afternoon, acute in the morning, we know that there's refills of prescriptions are going to be different than, hey, I need to communicate with Dr. Volroth because my daughter won't talk to me anymore, or whatever. Like, there's different things, and we help. It's a conglomeration of services. So when you're hiring us with billing, it's not just, we're going to, like, give me the code, and then I'm going to put it into your EMR, and then if it rejects, I'll see what's going on.
Yeah, it's the meta strategy for how to set your day up to optimize for billings in the first place. That's interesting.
Yeah, like, the actual submission of a code isn't billing. That's the entering of data, getting there in the first place, and then correcting anything that goes wrong. Like, the beginning and the end of the process, that's billing. The entering data, that's just entering data, right? Like, that's not a billing solution. So it's a bigger picture than that. It's a business management.
Very cool. Well, I guess before we wrap up here, province to province, let's say I literally just want to maximize my income potential as a physician. And this is sort of a hotly debated thing in the medical community. We see different pockets of doctors saying, okay, this province is better, this province is worse. And then the provinces themselves are like, disputing these things and saying, well, no, okay, we pay the most and here's our reasoning. Like from your guys' perspective, what is the most lucrative province to be in?
Yeah, if so, loaded question. But if we're taking a physician that is working in clinic and doing hospital rounds, it's going to be Alberta,
Okay, let's go
followed
Alberta.
very, very closely by BC. Now, this could be changing. BC is doing a different kind of hospital payment plan. Okay, so BC adapted its clinical payment structure. That BC's LFP pays more than Alberta's PCPCM. Okay, so if we're talking clinic to clinic, BC's
Yep.
paying more. Okay, when you throw the hospital in, now Alberta is going to be more lucrative. BC's changing their hospital payment structure away from their MSP payment structure a little bit, so maybe this changes. Now, honorable mention to Manitoba. They've got which used to be the absolute lowest pay scale in Canada. Okay, so honorable mention to Manitoba now. Saskatchewan is, if you're in an ARP, or like a an ARP scenario where you're getting paid a daily rate, your per patient per hour, the debate could be I get paid more per patient. I'm only seeing 13 patients and I'm getting paid a flat rate of this, right? So depending on the lens that you're looking at it through, end of the day, Ontario is way down. Nobody can argue that. It's just if they do, they're wrong. Unless you're in so they had umbrellas of family health in Ontario. So one of those umbrellas of family health has like an old boys payment plan where you get a top up model. They don't offer that anymore, but there is still is an environment of one of the umbrellas of family health where you get paid a lot more for being in one of those umbrellas. Nobody knows quite how you got into that umbrella or how you stay in that umbrella. But I would say if we're going apples to apples, it's Alberta if you're in hospital as well too. If you're a clinician, you're only working in family health and taking care of patients in clinic, it's BC. And that's just the way it is. There's 8 payment models in Alberta, Jordan. But with all the blended caps and the ARPs, the fee-for-service, PCPCM, there's 2 in BC, there's 2 in Saskatchewan, there's 1 in Manitoba, there's a few in Manitoba, blended cap and whatnot. But I mean, coming from me, Western Canada, the highest paid.
What about for the undifferentiated medical student who still doesn't know what kind of doctor they want to be? Which doctors make the most?
Yeah, so you are going to be that's loaded too. You want to be a locum physician, locum hospitalist, you can make a ton of money. A
Yeah.
ton of money. If you want to get into how do you want to practice and what life do you want to live? Is what I conference quite a bit and I talk with residents, I talk with students. And so what are you interested in? Let's start there, would be what I tell people. Like, what kind of medicine do you want to practice? And then what do you want to do outside of medicine? Is like, sky's the limit. What do you want why are you in medicine would be what I would say. Like, do you want to practice medicine in an Indigenous community because you want to take care of people that really need it, right? You're not going to be in Mackenzie, BC in the most glorious backdrop on the entire planet where you're a hiker and you're an adventurer, that kind of thing. You're in medicine because you want to take care of people, and your winter is probably going to be like -1,000, and your summer you're going to have bugs the size of birds. So there's that. So why are you in medicine? And then if it's for money and money only, then your day looks different, than if you're in medicine for a different reason. And that's not right, wrong, or otherwise, right? Like, if you're in medicine because it is legitimate way to an amazing lifestyle, and a positive income, and the kicker is that you're taking care of people in the process, right? Then I'd go work probably in Alberta. If you want to live in an amazing place in an island community somewhere, I'd say go in BC. If you want to provide healthcare where it is desperately needed, you're probably going to be in Saskatchewan or Manitoba or Northwest Territories or Yukon. Like, I mean, there's the sky's the limit. Why you want to be in medicine is what I
Yeah,
tell
there's too
people.
many intra-professional different ways of practicing that are going to influence things more than just which
Right?
residency program did you do? How much are you grinding it out? Where are you practicing?
Yeah, why are you here in the first place? Tell me that, and then I'll tell you where you should probably go look. And then on top of that, I'll tell you So we've got clients all over the place and everybody needs physicians, right? So why would you go to this location over that location? Can you please explain to me the different payment models, right? Like that's this part two of the equation. And then we'll go into like what lifestyle stuff. And like I've answered those questions for people. That's just the way that it goes, you know?
Awesome. Well, Kyle, thank you so much for sharing that with us this morning. It was really engaging. Appreciate your time today.
Yeah, absolutely. Thanks for having me. I really had a blast. So my first podcast. Glad I was with you, Jordan.
There we go. If anybody's looking to get in touch, they're interested in the fractional virtual MOA or even the billing side of things, where do they find you?
They can go to sherrittservices.ca, 2 R's, 2 T's, and Sherritt. Or just Google Sherritt, Sherritt Services. Or, get a hold of you. You've got my phone number. It's the easiest way you can get a hold of us through the website, or Kyle at sherrittservices.ca,
Awesome. Thanks again.
Well, thank you, Jordan. Take care.